Greetings, everyone, and thank you for joining our program today, Psychology Meets Biology and COVID-19, What We Know and Why It Matters for Public Health. My name is Robert Gropp, and I'm the Chief Executive Officer of the Association for Psychological Science, an international scientific organization with about 25,000 members around the world, dedicated to advancing research psychology for the benefit of science and society. Thank you again for joining us for today's important program. This is part of our ongoing series, a global collaboration on COVID-19, which is APS's effort to convene scientists from around the world, as well as other related fields, to discuss, explore, and consider how we can better respond to the COVID pandemic, as well as find solutions and hopefully better responses to future crises that ultimately have human behavior at their core. Again, today's program is organized by members of this collaboration, specifically a work group focused on the working and looking at the intersection of biology and psychology and its relationship to infection. So without further ado, I would like to turn today's program over to Dr. Sarah Pressman, who is one of the organizers of the initiative of the program today, and will serve as your moderator and host. I know I'm eager to learn from today's discussion and presentations. So without further delay, Dr. Pressman, thank you.
Thanks, Rob. And thank you all so much for joining us today. We know that at this point in time during the pandemic, so many of you are overwhelmed with work, with illness, with care responsibilities, never-ending complications. And we're honestly, truly honored that you're joining us today to learn about the importance of psychology for health during this never-ending pandemic. When we started planning this meeting months ago, little did we know where we would be. We really had no idea that we would be right at the top, so much higher than at any other point of the pandemic. And so obviously, it's never been more important to learn about this critical health connection and possible new ways for us to be thinking about how to stay healthy right now. Also, when thinking about the importance of this topic, I think that Francis Collins, the outgoing director of the NIH over the last 12 years, he said it really well when he was reflecting on what he thought the NIH could have done better over the last years. And what he said was, maybe we underestimated research or underinvested in research on human behavior. And that's because he just couldn't believe that a year after the vaccine was available, that millions and millions of Americans were still not opting to have their vaccination. Now, vaccine hesitancy is one thing we'll be talking about today, but there's also so many other behavioral health, psychological variables that are critical to determining how healthy we are in the face of this virus. So our first goal of today's session is to have an incredible lineup of speakers share with you in just a few short minutes each, the most important science concerning how psychological, social, cultural, and behavioral factors shape infectious disease outcomes, immunity, vaccine responses, and health, both before the pandemic even started and right now during the height of this pandemic. But our other goal is to really think about how can this wealth of important data be better used. Psychological scientists have not really been involved in as big decisions were being made about how to survive this pandemic and plan for it. And so one of our activities today is to really think about what can we do so that this work makes a bigger difference in helping people stay healthy and well during this awful time. So to this end, today we'll be having discussion and questions facilitated by an amazing group of discussants coming at this problem from three very different perspectives. And they are Dr. Amy Greer, who is a Canada Research Chair in Population Disease Modeling at the University of Guelph, Dr. Roxy Silver, who is a Distinguished Professor of Psychological Science, Medicine, and Public Health at the University of California, Irvine, and David Robson, who is an award-winning science writer and author of many books focused on the interplay between human brain, body, and behavior at the extremes. And so you'll see this wonderful team popping in and out, asking clarification questions, and then critically leading a really engaging and exciting discussion in the last half of the session. But of course, we want to hear from you too, not just our discussants. And so we're going to invite you to also ask questions of us today. There's a Q&A, question and answer function on Zoom, and we want you to put your questions in there, and then also to upvote your favorites. There's a thumbs up function. There's a thumbs up function in the Q&A. And so what our team will do is after the break period, halfway through the meeting, we're going to pass those most upvoted questions on to the discussant team during our break period. Now, we're not having our speakers necessarily answer your questions in real time because we want them focused on the talks, but we do promise to pass those on later and hopefully discuss many of them during our second half of the meeting. So with that, let's kick off part one of this meeting, focused on evidence from before the pandemic started on the psychosocial, contextual, and behavioral influences on viral and infectious disease outcomes. We called this section the pre-pandemic insights. And we'll be kicking this off with the wonderful Dr. Keely Muscatell, who is an assistant professor at the University of North Carolina at Chapel Hill. Take it away, Keely.
Hello, everyone. Thank you so much to the organizers and to APS for convening this really important conversation today. I'm really excited to share a broad overview of the biological mechanisms that are important for linking psychological processes and infectious disease outcomes. And I'm hoping that my talk today, kicking things off, will sort of be a broad overview of themes that we'll come back to throughout the rest of the day today. So I'm going to focus in my talk specifically on the immune system as one biological system that's critically relevant in the context of infectious disease, and that's also influenced by psychosocial processes. So to dive in, I wanted to give a very brief overview of the immune system, and specifically talk about these two branches of the immune system that are critical for understanding infection. So the first is the innate immune system, and the second is the adaptive, or sometimes called the specific immune system. So the innate immune system, you can think of as the fast-acting, on the order of minutes or hours, kind of first responders to an injury or an infection. Think of these as like your EMTs. They are non-specific, so they're able to deal with a whole host of different problems, and they come online really quickly to try to provide a first response. A key process that the innate immune system orchestrates is the inflammatory response that you'll hear a lot about today. And key players in the inflammatory response are proteins called cytokines. Now, on the other hand, we have the adaptive immune system, which is the slower branch of the immune system that unfolds over the course of days or weeks. You can think of these as sort of your surgeons or your specialists coming in to tackle a very specific problem. So again, this is a highly specific branch of the immune system. And while it's very complex with a lot of players, one key process is cytotoxicity, or the ability of cells to eliminate and kill off antigens, and proliferation, the ability of these cells to activate when they are told to. Key players in the adaptive immune system, among other types of cells, are T cells. So in a well-functioning immune system, we want our innate immune system to be relatively inactive when everything is fine in the body. So we want levels of cytokines in the bloodstream to be low, just like you don't want your EMTs out roaming the streets when there aren't any emergencies. And when an issue is encountered, like a virus, you want your innate immune system to spring into action really quickly, just like you want your EMTs to show up in an emergency quickly. But you don't want to mount too big of a response or too long or prolonged of a response. So you want the innate immune system or the inflammatory response to activate quickly and not too strongly, and then shut down relatively quickly as well. Just like with your EMTs, you don't want 20 ambulances showing up during an emergency, and you don't want all of them to follow you to your follow-up appointments. And for our adaptive immune system in a well-functioning body, we want our T cells to be highly cytotoxic, or good at eliminating and remembering the viruses we encounter. And just like we want our surgeons to be well-educated and have a lot of experience extracting things from the body, that's the same thing we're looking for in our adaptive immune system. So what do we know about psychosocial risks to the immune system? Well, there's a large body of evidence that factors like unemployment and other socioeconomic factors like low income, low levels of education, that encountering discrimination in the environment, that experiencing chronic stress or feeling like your difficulties are really mounting up and you can't cope with them, and experiencing loneliness or feeling like you don't have a social network or people you can turn to. All of these psychosocial risks have robust influences on the immune system. Specifically, they cause our innate immune system to be overactive, so we have higher levels of inflammation, and they cause our adaptive immune system to be less effective, so lower cytotoxicity. So all of these factors have been extensively studied in psychological research and have been shown to link to higher innate immune system activation and lower adaptive immunity. It's not all bad news, though. There are some psychosocial protections for the immune system. So factors such as social connection, feeling like you're part of a community, having purpose in life, experiencing positive emotions, and giving to others are associated with enhanced immune functioning. So lower levels of innate immune system activation, lower inflammation, and a better functioning adaptive immune system, higher cytotoxicity. And it doesn't take much to imagine how these things can combine in the context of COVID. So if someone has pre-existing psychosocial risks like stress, and that is combined with pandemic-induced psychosocial risks like unemployment and loneliness, that can lead to increases in inflammation. And in turn, when encountering a COVID exposure, that could lead to this cytokine storm that we know is really critical in driving COVID symptoms. And I think in light of this, there are important implications for future pandemics that we'll talk about today. And I am going to wrap up there in the interest of time. Thank you.
Okay, thank you so much, Keely. And I'm sorry we had to cut you off. And so I'm just going to leave your slide up for a second so people can read it over as we introduce the next speaker, who is Dr. Anna Marsland, who will be coming to us from the University of Pittsburgh, where she is a professor of psychology. Welcome, Anna. And I should also know Anna is one of the co-organizers of this meeting.
Thank you very much, Sarah, and thank you, APS, for hosting this. I'm really excited about how this will unfold in our discussion today. It's my honor to present findings that really are going to be, is the summary of the work that's has been done by my friend and colleague, Sheldon Cohen. Sheldon is a professor of psychology at Carnegie Mellon University, and for the past 35 years, he has been conducting really well-controlled trials examining factors that predict susceptibility to respiratory infectious disease. And of course, this seems is very relevant for the pandemic and for our response to COVID infection. I'm trying to change my slide here. Okay, so Sheldon's model here, he's used viral challenge studies, and these are, as I said, controlled studies where healthy volunteers agree to participate. They are characterized very well on a range of psychological and social factors, things like levels of chronic stress, their social relationships, their socioeconomic status. They're also very well characterized in regard to their lifestyle behaviors, things like their sleep, their eating, exercise habits. After they have been characterized, they are experimentally exposed to an upper respiratory virus. Sometimes they're cold viruses, sometimes they're flu viruses, and then they're quarantined for 5 to 6 days and very closely monitored to see who becomes infected and who develops symptoms of clinical illness. Lots of covariates are considered in these studies, really to try and take a look at these psychological and behavioral factors and how they may relate to risk for developing respiratory illness. Interestingly, the findings across many trials over the past 35 years show that 70 to 80% of those who have been exposed in this way to the virus do become infected. And of those 70 to 80%, 25 to 40% across trials actually develop symptoms of upper respiratory illness. In regard to predicting who gets these symptoms and who doesn't, there seems to be a real pattern that's relatively consistent across trials. So in regard to health behaviors, no surprise here, individuals who smoke, individuals who exercise less than 2 times per week, individuals who get less than 6 to 7 hours of sleep per night and don't sleep well, and those who eat a diet that's low in vitamin C. These have been relatively consistent findings across trials and associated with increased risk of clinical illness. But what's really interesting to us today is also the consistent evidence that psychological and social factors also associate with risk for illness. So particularly levels of chronic psychological stress. And even within stress, interpersonal stress and employment stress are particularly provocative. And so individuals who are high in these are more likely to develop clinical illness than those who are not. In addition to stress, individuals who report high levels of depression and anxiety, and individuals who report fewer social relationships and less social support are at risk of clinical illness. And this is just some of the data here to show you this, some of the primary findings from different trials across a long period of time. But here this data shows in regard to interpersonal and work stressors, this is the odds ratio, the risk of getting clinical colds. And you can see here compared to no stress or other types of stress, interpersonal stressors and work-related stressors are associated with a quite significantly increased risk of developing clinical colds. In this graph here, you can see that individuals, this is the amount of social contact, the number of people in people's social networks, and increased numbers of people in the social network are associated with decreased risk of colds. And down here, you can see that among individuals who report high levels of perception of stress, those who have high levels of social support are somewhat protected. So social support buffers the impact of stress on risk of disease. Dr. Cohen's work has tried to examine why is this the case? Why is stress so bad in regard to getting clinical illnesses? You might think that it's health practices that account for this, and certainly health practices are independently related to risk of getting clinical illness in his research, but they don't actually really account for much of the relationship of stress with risk of disease, nor does activation of biological pathways. What really has come out in the studies, and this relates to what Keely was just talking about, is that chronic stress relates to increased inflammation, and that increased inflammation, the inflammatory response, relates to increased risk of disease. So a summary here is we need to think about the implications of this for COVID. Sheldon has looked at over 10 different viruses, including a different strain of coronavirus. Findings have been consistent that increased stress, interpersonal stress, work-related stress, decreased social support is associated with increased risk of illness. And we think this is very relevant in the context of the current pandemic and is something for us to think about in our discussion today. We also raises the possibility that some of our mitigation practices for COVID-19 might actually increase the risk of vulnerable individuals. Thank you very much.
Thank you so much, Anna. Okay, moving on to our next wonderful speaker of this part 1 session, Dr. Rodlescia Sneed, who is an assistant professor in the Department of Family Medicine in the Division of Public Health at Michigan State University.
Thank you, Sarah, and thank you to the committee for inviting me to speak today. So the previous speakers have talked quite a bit about psychosocial factors that contribute to increased risk of infectious disease. And what I'd like to do is to talk briefly about racial and ethnic disparities in some of these psychosocial factors. So first of all, we know that there are large racial and ethnic disparities in infectious disease. If you look at the graph on the left, it looks at the percentage of cases of tuberculosis in the United States by race and ethnicity. And in the US, we know that 57% of the population is white. However, whites account for only 11% of tuberculosis cases in the United States. We see a similar pattern when we look at influenza. The graph on the right shows rates of hospitalization for influenza by race and ethnicity. And we can see that the highest rates of hospitalization for influenza are among non-Hispanic Blacks, Native populations, and Hispanics. When we think about racial and ethnic disparities in infectious disease, we can think about factors that contribute to increased exposure to disease, and also factors that contribute to increased susceptibility to disease once you are exposed. And two important factors that contribute to exposure are crowding and occupation. Presumably, if a person in your household has an infectious illness, you'd want that person to isolate so that they avoid transmitting infection to other household members. However, that's very difficult if you live in a crowded environment. If you look at the graph on the left, it shows the percentage of US households that have more than 2 people per bedroom by race and ethnicity. And what we see is that non-Hispanic Blacks and Hispanics are much more likely to live in crowded households than whites. And this has implications for infectious disease exposure. Likewise, if we look at occupational risks for exposure, if you look at the graph on the right, we see that Blacks and Asians in particular are more likely to have workplace exposure to infectious disease agents. Additionally, we see that among Blacks in particular, they're more likely to work in close proximity to others than other racial and ethnic groups. And so that has implications for infectious disease exposure as well. We can also think about factors that increase susceptibility to disease once you are exposed. One important psychological factor is chronic stress, as the previous presenters discussed. So if we look at chronic stress, we can see that Blacks and foreign-born Hispanics report more health-related stress and more financial stress. Additionally, if we look at Blacks, they report more residential stress and more relationship stress as well. If you look at the graph on the left, we can see that perceived discrimination is also an important factor. The graph on the left shows the percentage of adults who perceive racial discrimination in healthcare. And in particular, if we look at Blacks, we see that Black Americans in 2020, 70% of them reported that the healthcare system seems to treat people unfairly based on their racial and ethnic background. And this is much lower than other racial and ethnic groups. And if we think about discrimination, this can be important when we're thinking about chronic stress. Discrimination in itself can be a type of chronic stressor. And discrimination can also be important if we're thinking about its impact on healthcare utilization. And then finally, we can think about health behaviors that also increase susceptibility to infectious disease. Two important health behaviors that I'll talk about are sleep habits and vaccination. So if we look at the graph on the left, we see that 19% of whites report that they get less than 6 hours of sleep per night, compared to 43% of Blacks, 31% of Hispanics, and 37% of Chinese Americans. If we look at the graph on the right, we can look at vaccination rates as well. If we look at vaccination for influenza, we see that there are significant racial and ethnic disparities as well. Blacks, Hispanics, and Native populations are much less likely to be vaccinated for the flu than Asians and whites. And we see that this pattern is true when we look at the 2019 to 2020 flu season, as well as the 2020 to 2021 flu season. And so when we think about all of these factors and their implications for COVID-19, we know that the recommended practice during COVID-19 has been social distancing. But individuals who have occupational risk or those who live in crowded environments may have limited opportunities for social distancing. Additionally, we can think about perceived discrimination and the way that it likely contributes to low vaccine confidence among racial and ethnic minorities. And finally, given what we know about stress prior to the pandemic, We know that there are racial and ethnic disparities in stress, and these likely contribute to differences in immune response and also differences with respect to health behaviors among racial and ethnic minorities. And I'll stop there. Thank you.
Thank you so much, Rodlescia, for the great talk. So this ends our part one, some of the wonderful insights from science on pre-pandemic findings in this area. We wanted to now give our discussants an opportunity to ask any clarification questions. As I said up front, most of our questions we're saving for the larger discussion period in the second half of this session, but do indicate what questions you have in the Q&A and upvote the questions that you like so we can share them. But let me just ask the discussants, did any of you have any clarification questions that you wanted to ask of these three speakers before we move on?
I don't.
It was super clear to me, so thanks so much. I did just wonder with the first presentation from Keely Muscatell, because she had to kind of miss that last slide on the kind of implications of this research. I wondered actually if we could just look back at that and if she could just tell us for a couple of minutes kind of what these implications are.
That would be
Yeah,
great.
to do that. Sorry, 5 minutes goes so fast. Yeah, I mean, I think we'll revisit a lot of these throughout the day today, but I just wanted to kind of plant the seeds that I think given what we know about psychosocial influences on the immune system, there's lots we can do to try to sort of eliminate some of the issues in the face of future pandemics. So, you know, enhancing our social safety net so that issues like poverty and unemployment aren't sort of leading people to have immune systems that are less effective, developing strategies to mitigate, you know, policies like social distancing, which can increase loneliness. And like Dr. Marsland said, sort of some of those things that we're asked to do can actually increase the psychosocial risks that we know exist. I think it's critically important to recognize the impact of mental health issues like depression on physical health like inflammation, and be, you know, providing affordable care to those who need it around those issues. And then also kind of building up our resilience resources by enhancing social connection and providing opportunities for people to contribute meaningfully. And I think if we're able to do that, we'll hopefully face the next pandemic in a little bit better state.
Cool. Fantastic, thanks. Yeah, I mean, I think that is really worth emphasizing, so thanks for explaining that.
Thanks.
Okay, Amy or Roxy, did either of you have any points of clarification you wanted to make before we moved on?
No, I don't. Thank you.
Sarah, I was thinking, you know, one of the things that jumps out from all of the presentations so far is, you know, this idea that mitigation measures, and I come from a public health background, so, you know, we implement all of these mitigation measures, but that they may increase risk, right? And to me, that's, it's amazing in terms of the biology and the psychology and the psychosocial components of that. But for me, the big question is like, the communication of that is very nuanced. How do we incorporate that in terms of public health interventions or mitigation measures in a way that helps to better support people, while at the same time, you know, protecting public health? Because just that statement alone is really challenging because there's a lot of nuance around that, and so it's really eye-opening.
Amy, I hope that we'll have the opportunity to discuss that during our discussion section later in the afternoon.
100%. I think this will be one really key thing for us to talk about as we really struggle with how do we implement some of this into change to keep people healthy, right? And how do we create the right messages? So thank you everyone for all the speakers and the discussants for this part one. And we'll be moving into now pandemic insights, which is evidence being collected at this moment on how these psychosocial and behavioral factors are connecting to COVID. And we'll kick it off with Dr. Adam Geraghty, who is an associate professor in the School of Primary Care, Population Sciences, Medical Education at the University of Southampton.
Brilliant, thank you. Hello from the UK. So what I'd like to do very briefly is talk about some of the kind of global data that there is now on the psychological impact specifically of the current pandemic. So as we've kind of gained some insights of already, pandemics impact on mental health through a number of kind of mechanisms. There's the direct route by, you actually get the illness itself, and that has implications. There's lots of fear and lots of loss in many different kind of contexts, whether it be loss of roles or loss of close social others. There's impacts on employment, both through the loss of jobs based on government changes to restrictions, etc., but also loss of or changes in employment potentially based on people changing their behaviors based on their own assessment of risks. So lots of different ways a pandemic, respiratory pandemic in this case, can impact on people's mental health. So what I'd like to do is just summarize some of the key systematic reviews that have been conducted on studies that have looked specifically on mental health impact, focusing for the most part on the general population and looking at the kind of global picture. These studies use primarily cross-sectional methods, so survey studies, and these a range of measures, including the PHQ-9, the Beck Depression Inventory, all these kind of common scales that might be familiar to psychologists on this kind of webinar, but they're essentially questionnaires measuring depression symptoms, anxiety symptoms, and general distress symptoms. So before I get to the kind of key table I'd like to talk about, it's just a kind of as a comparator really, to look at the prevalence, which essentially means commonness, of depression symptoms and anxiety symptoms or disorders pre-pandemic. So in the work that the World Health Organization did in 2015, depression was at 4.4% and anxiety disorders or anxiety symptoms probably were at 3.6%. So that's the pre-pandemic global picture for depression and anxiety symptoms. So moving on, this is a tad small, but so these are 6 systematic reviews of general population surveys measuring mental health. And as you can see from the countries included column, a lot of work has been going on in this area globally. So a huge number of countries have been doing these studies, and those have been included in these reviews. The Nochewong paper published in 2021 is perhaps one of the most robust systematic reviews here. And you'll see, if you look down the prevalence columns for depression and anxiety and general distress, there is obviously variety, but we're looking at around kind of 25% to 30% on average of these samples reporting heightened levels of depression, anxiety, and general distress. And that increases further when we look at the general distress, kind of if you like broad distress rather than specific depression and anxiety symptoms. There is variance around those numbers, of course, and in Nochewong's study, they looked at that specifically and found that that varies depending on number of hospital beds per 10,000 in the population. The lower that number is, the higher the likely symptoms of depression, anxiety, and general distress. And also the higher the human development index, the less likely or the lower the prevalence of depression, anxiety, and general distress symptoms. So that's the picture from the kind of general population studies. Just to quickly give a bit of an indication from 2 specific populations, particularly children and healthcare workers. Another systematic review here done in 2021, looking specifically at youth and children. Again, really looking at, including studies from all across the world there, found in the majority of studies increases in depressive symptoms, and in all studies they reported increases in anxiety symptoms. That was a narrative review, so they don't report prevalence figures. Uphoff in 2021 looked at the mental health impact of care workers, and again that was a review of reviews. And you can see there through the list of countries, again, this work has really been done globally, so we can get a good indication there. In terms of the prevalence rates for anxiety and depression and distress, they're similar to general population rates, but probably just slightly higher for perhaps obvious reasons around the kind of exposure to stresses, but still a large impact. Briefly, I just wanted to mention some work we're doing here in Southampton in the UK that will come out later in this year. A similar kind of study that was done globally, but particularly with a focus on people who had confirmed COVID and those people who didn't have confirmed COVID, and with a longitudinal follow-up looking at mental health symptoms, and that will be published in 2022. So the take-home message from this brief section is really, compared to pre-pandemic levels of depression and anxiety, again, around about 3.5% and 4.5%, it's clear that this respiratory pandemic has had a very, very large impact in terms of mental health symptoms globally. And that's really the key take home and where I'd like to stop. So thank you.
Thank you so much, Adam, for your wonderful talk and data. So we're moving on now to Dr. Kavita Vedhara, who's a professor of health psychology at the University of Nottingham and also one of the organizers of this event today.
Thank you, Sarah. Just wait for my slides to come up. Great. Thank you. So we've learned several really important things from the speakers so far. I think firstly, we've learned from Adam that there is little doubt that this pandemic has resulted in widespread psychological distress, and that's occurred across the world's population. Secondly, we know that this distress, although obviously a really important outcome in its own right, it can have effects on physical health too, through its enduring effects on our biology. And thirdly, and perhaps most relevant for today, we know from decades of research in the context of other viral infections, including other coronaviruses, that distress can influence both vulnerability to infection, but also disease severity. So for me, and I hope for the audience also, the elephant in the room is this question: has psychological distress influenced our COVID-19 outcomes? And what I'd like to do is spend just a couple of minutes presenting you with some data which I think speaks to this question. The first data come from people with a history of psychiatric disorder. Now, of course, these individuals represent just one end of the mental health continuum, but they are a really important group because we know that the psychological impact of the pandemic has been particularly brutal for them. But is there any evidence that their COVID-19 experience has been any different to the wider population? So this is analysis that was conducted by Yang and colleagues in an analysis from the UK Biobank, which is a prospective cohort of over 500,000 people in the UK whose data are linked to medical records. So what they did was they identified just over 50,000 people who had a clinical diagnosis of a psychiatric illness prior to the start of the pandemic. And they compared the COVID-19 outcomes of this group with the rest of the cohort. And what they found was really quite striking. Firstly, they reported that people with a history of psychiatric disorder were much more likely to be diagnosed with COVID-19, but they were also more likely to be hospitalized and to die. And this risk was not negligible. It was between 1.5 to 2 times greater. But these individuals obviously are just one end of the mental health continuum. What about the general population? What about the stress that you and I have experienced during this pandemic? Is there any evidence that it also has impacted on our risk of getting COVID-19? Well, we've recently published a study that provides some preliminary insight into this from a cohort we established in the UK very early on in the pandemic. We conducted analyses from over 1,000 adults who provided us with data on their psychological distress early in the pandemic in 2020, and then their self-reported COVID-19 outcomes over an 8 to 9 month period later. And what we see is a very familiar pattern. The people reporting the greatest distress at the start of the pandemic were much more likely to report COVID infection, a greater number of symptoms, and also greater symptom severity. So taking just those two pieces of the jigsaw together, then, we do see very clearly some evidence pointing clearly at psychological distress as a risk factor for COVID-19. But there's also evidence on mechanisms, and it's very likely that if this is a real effect, that both biological and behavioral mechanisms are at play. Some of the earliest evidence that has been published in recent months, though, has focused on biological mechanisms and has focused specifically on the stress hormone cortisol. Cortisol plays an important role in connecting our emotional well-being with our physical health, and it does so in a variety of mechanisms. But just to keep it simple, I think it's helpful to think of it in terms of the more cortisol you have, the greater the potential for dysregulation of your immune system. And some of the earliest data on cortisol in this pandemic have again come from those people you'd expect to be experiencing the greatest distress, namely healthcare workers on the front line. We now have several papers which point very clearly to healthcare workers exhibiting significant increases in their cortisol levels related to their experience of psychological distress. But again, relevant to ask the question, well, are we seeing any changes in cortisol in the general public? Here again, we've got some very early data, and I'd ask you to treat these with caution because This data is under review. It hasn't been published yet, but we were able to look at cortisol levels over a 6-month period in over 800 people in a general population sample in the UK. And we observed 2 things in our data. Firstly, there has been a significant increase in this population of almost 25% in cortisol levels compared with pre-pandemic levels, and that the greatest increase is in people with a history of psychiatric illness and also the highest levels of stress. But you're probably saying, well, what's the evidence that cortisol's linked to COVID? Well, here too, we have some emerging evidence. An opportunistic study of COVID-19 inpatients found that the risk of mortality was greater in patients with the highest levels of cortisol. Their days of survival were more than halved. So, putting all that together, what does it mean for public health? Well, I'd like to suggest to you that what it says to me anyway, is that maybe it's time to consider psychological distress as a potential risk factor in the way that we view age and other clinical conditions as risk factors for COVID-19. And if we're serious about dealing with it, then we need to develop surveillance systems which not only monitor the virus, but monitor the public as well in real time. Thank you.
Thank you so much, Kavita. And we'll now be moving on to Dr. Hannah Schreier, who is an associate professor of biobehavioral health at Penn State University.
Great. Hi, everyone. Thank you so much for having me. I'm going to use my short 5 minutes to talk a little bit more about the effects of chronic stress exposures on youth health outcomes in the long run specifically. And so there we go. We know that chronic stress does impact youth health. Many youth do already experience chronic health problems. And in addition, we also know that the effects of chronic stress on physiological health outcomes and chronic disease risk markers can already be seen in these age groups. And so, for example, we know that youth who grow up in poverty are more likely to experience worse asthma or obesity outcomes during childhood and adolescence. And you can see the growing divergence in obesity rates among lower and higher SES youth here, such that lower SES youth are increasingly likely to be more obese than their higher SES counterparts. What we also know is that lower SES youth are more likely to develop chronic diseases of aging later on in life, for example, heart disease. And you can see that here in this longitudinal study of a cohort of physicians who were followed over multiple decades. And we see that even though these same individuals become more affluent later in life, there's still an effect of lower childhood SES on later life disease risk, suggesting that there's something uniquely important about exposures during the early years. We also know from other research that youth who experience other adverse events, such as child maltreatment, are similarly more likely to develop chronic diseases of aging later in life. And so there are numerous ways in which chronic stress has increased among youth during this pandemic. First of all, youth are spending more time at home and in close quarters with their families and are thus more likely to experience spillover effects of their parents' stress exposures. So we've seen that substance use rates among caregivers have been going up, and we've also seen that many caregivers have been experiencing additional stressors themselves, for example, in terms of housing or job insecurity or needing to perform jobs in higher risk and more stressful conditions. And so in addition to that being directly stressful for the caregivers themselves and taxing on them, that is also likely to spill over and impact the broader home environments that youth are living in. And then finally, and very sadly, we've also seen an unusual number of youth who've experienced bereavement during this pandemic because caregivers or other close family members or friends have passed away as a result of COVID-19. Other important considerations are that during school closures and lockdowns, but also just during the pandemic more generally, youth have been much less likely to come into contact with peers who are very important sources of social support, and they've also been less likely to come into contact with other adults who may be sources of support, but who also may be mandated reporters. So these are adults, for example, teachers or physicians who are legally required to report suspected child maltreatment. And a direct consequence of that is that youth are more likely to be stuck in dangerous and potentially stressful situations at home and to be exposed to such adversity for longer periods of time and with a lower likelihood of intervention. And that in turn means that this pandemic has the potential to compound the effects of already existing stressors that youth were exposed to perhaps already prior to the pandemic, and that these higher risk youth may in fact be especially hard hit. I also want to point out and be very clear, though, that not all youth who experience chronic adversity will experience poor health later in life, and that many youth are in fact resilient in the face of adversity and lead not only productive, but also healthy lives. And so researchers have focused increasingly on trying to better understand the influences on youth lives that are beneficial and protective of health, even if youth are faced with adversity. And so similar to what others have already shared about research based in adults, we know that in youth too, those who grow up in warmer and more supportive homes and those who have stronger social ties are less likely to experience the negative physiological consequences of chronic stress. There are also now several studies that have shown that we can actively shape these chronic disease risk markers among youth. And there are two studies I'll share that have shown that psychosocial interventions have actively improved markers of disease risk among youth from lower socioeconomic status backgrounds, even though the interventions themselves did not focus on health-related issues per se. And so in this first study, the results of which you can see here, 19-year-olds who taken part in an intervention to strengthen family relationships together with a parent when they were 11 years old had lower levels of several markers of inflammation that might impact disease risk in the long run compared to youth who had not been part of that intervention. And then in another study, we've seen that among 10th graders, those who were randomly assigned to volunteer with third graders after school programs, those kids showed improvements in several physiological risk markers of chronic disease risk compared to youth who were randomly assigned to weightless control groups. And so together, this suggests that even in the face of chronic adversity, many youth can fare quite well, but importantly also points to the idea that when we're thinking about improving physiological health outcomes and chronic disease risk markers, that there may be value in thinking beyond medical intervention and prevention efforts and to also consider these psychosocial interventions in more detail. Thank you.
Thank you so much, Hannah. Okay, we're going to move on next to Dr. Julianne Holt-Lunstad, who is a professor of psychology and neuroscience at Brigham Young University.
Thank you so much. I'm incredibly grateful for the opportunity to briefly highlight the scientific evidence concerning social connection. And given the restrictions associated with the pandemic that have encouraged, required, and in some cases enforced limiting social contact, it is critical to understand the potential secondary public health consequences. And of course, concerns about social isolation and loneliness unfortunately have primarily focused on mental health. However, as presented in many of the earlier presentations, there's evidence that these recommendations and policies may have potential negative physical health consequences as well. So I had the honor of serving on a National Academy of Science committee that issued a consensus report on the medical and healthcare relevance of social isolation and loneliness. And after a thorough review of the body of evidence, the committee found substantial evidence that social isolation and loneliness are associated with a greater incidence of major psychological, cognitive, and physical morbidities and lower perceived well-being or quality of life. Some of the most compelling evidence comes from the association of social isolation with significant increased risk for premature mortality from all causes. This led the committee to conclude that social isolation is a major public health concern. Now, ironically, this report was published February 27th, 2020, just 2 weeks prior to the World Health Organization declaring a global pandemic. So the evidence was pointing to a major public health concern even prior to the pandemic. So just to highlight some of this evidence, there's now multiple meta-analyses, including hundreds of prospective studies and millions of participants that provide converging evidence pointing to social isolation and loneliness as independent risk factors for disease-related mortality. And conversely, social connection as a protective factor. Furthermore, there's evidence demonstrating risk of social isolation and loneliness among non-fatal health outcomes, including physical health outcomes, such as increased risk for cardiovascular disease, stroke, type 2 diabetes, mental and behavioral health, including depression and anxiety, suicidality and addiction, cognitive health outcomes, including greater risk for mild cognitive impairment, dementia, and Alzheimer's, and even potential implications for economic health, including evidence that isolation has been linked to 6.7 billion in annual Medicare costs, and the economic cost to society may be much larger, given some studies linking social isolation and loneliness to lower workplace productivity, greater absenteeism, and lower quality of work. So taken together, these findings suggest further long-term health implications of the pandemic that may occur if steps are not taken to mitigate risk. There have been several studies that have examined whether loneliness has gotten worse as a result of the pandemic, or whether people have been resilient. And most of this evidence was cross-sectional or retrospective surveys. However, the authors of a meta-analysis that is currently under review identified 32 independent longitudinal studies. And overall, their findings suggest that both the prevalence and severity of loneliness has increased since the pandemic. Now, despite strong evidence of the relevance to health, there are still some important gaps in our understanding. So I'm regularly asked, just how long can we endure this? And at what point will we begin to see the effects of the pandemic? And while there is evidence of both long and short-term effects of isolation and loneliness, the exact time course of chronic disease development is less clear. The pandemic has also made clear the need for effective remote means of social connection, and there has been widespread scaling of various tech-mediated solutions. However, some evidence, or the evidence is mixed and complex. And so the benefit is unclear. In fact, there's some evidence to suggest that online interaction may not replace in-person contact, and dissatisfaction with such tools may be associated with greater severity of loneliness and poorer outcomes. So we need to be cautious about scaling tools without adequate evidence to avoid potential unintended negative consequences. Another major gap comes from a lack of consistent systematic measurement. If social isolation and loneliness were routinely assessed in medical settings and included in the electronic health record, we would be able to clearly link this to objective health outcomes of millions of individuals and understand and track the secondary effects, health effects. And similarly, if there were standardized measurements included in surveys to inform national initiatives such as Healthy People, we'd have a better sense of the public health impact and inform national health objectives. So there's strong evidence of the health effects of both social isolation and the protective effects of being socially connected. And so we need actionable steps to mitigate potential secondary health effects of the pandemic. And this includes raising awareness among the general public and among the medical and health organizations of the health relevance, the opportunity to reduce stigma, to activate programs, and to rigorously evaluate them. And then finally, each of these should be considered cross-sector lifespan approaches. Considering the pandemic, we've seen how everyone and every sector of society has been impacted by public health policy reducing social contact. We can potentially take this opportunity to identify policy across sectors to similarly be part of the solution. Thanks.
Thank you so much, Julianne. Our next speaker is Dr. Judy Moskowitz, who is a professor of medical social sciences at Northwestern University.
Hi, thank you, Sarah. I really appreciate the chance to present this work, and I especially appreciate the placement of this talk where it is, in that I think a lot of the previous talks tee it up really well. So my team developed and is testing a self-guided online program that targets positive emotion with the goal of helping people cope better with stress. Oops, sorry, I just lost my slides. There we go. Here are the skills we teach in the program. It's been shown to be efficacious in a number of different samples coping with different types of mostly health-related stress. When the pandemic started, when it was clear it was going to last a while, we started getting some requests for to make the program available to people, in my department actually at the university, but to make a version of it available to the larger public. So we did that. Sorry, I'm not. There we go. So we made the program available. We recruited widely, took all comers. The data were collected from May 2020 through, actually, I sent an update yesterday. It's through December of 2021. And people who enrolled in the study were given access to an online platform that took about 5 or 6 weeks, where they learned 1 or 2 of these skills each week and had a chance to engage in home practice. And then we conducted assessments at baseline, 8 weeks, which was post-intervention, and then at 12 weeks. We measured depression, anxiety, social isolation, positive affect, meaning and purpose, all using the PROMIS, which are NIH toolbox measures. We use computer adaptive tests, which were really great because they're a very efficient way to get to a precise measurement of these different sort of self-reported outcomes. So in terms of demographics, and this is something to keep in mind as I talk about the results, the sample was largely female, largely white, and highly educated. And this was a US-based sample. That was a restriction of our IRB. And one of the advantages of the PROMIS scores is that they're all normed. The national norm is at 50. So you can look at the average in your sample and compare it to what sort of the general population would have. So as you can see in this slide, at baseline, anxiety, depression, and social isolation were all significantly elevated. Meaning and purpose and positive affect were all lower, significantly lower than the general population norm. And then over time, people who had access to the program reported less depression, less anxiety, less social isolation, and increased positive affect and increased meaning and purpose. Now, one of the weaknesses of this study is that there's no control group. So it's possible that the people who are in the study are just reflecting a societal adjustment to the pandemic or to the stress of the pandemic. One way we can look at this, again, it's not perfect without a control group, but we can look at the scores on the outcome measures in people at baseline who are completing their baseline, and those are the dots in blue. And we can compare those to the people who are completing their post-assessment at that same time point. So here's August of 2020. The people in blue are completing their baselines at that point. The people in orange have completed their post. And when you compare these two lines, you see that the people completing their post assessments are definitely worse. This one's on anxiety. Their anxiety is definitely lower, sorry, worse, better. Their anxiety is lower than people who are just doing their initial assessment. And we see this same effect across all the other outcomes: depression, social isolation, meaning and purpose, and positive affect as well. So that's it, under 5 minutes.
Thank you so much, because we're already a little bit behind, so that's great.
Anything for you, Sarah.
Oh, thank you. All right, so with that, if there's any points of clarification from the discussants, we can hear them now for the last few speakers.
Sarah, may I ask a question?
Of course, go ahead, Roxy.
Okay, thank you. I'd like to ask a question of Adam. I was very impressed with the enormous sample sizes once you compile across the world the mental health impacts of COVID-19. But I want to just ask you about the quality of the studies. You said most of them were cross-sectional. What is the sample size? Are the studies non-representative? I have seen very few studies, prospective studies with probability-based representative samples that can help us elucidate the actual impact, rather than studies with potentially biased samples of individuals who may be motivated to report their symptomatology. Do you have any way of exploring that, or have you looked at that in particular?
A very good question, and the answer is I haven't. And I think that is all the things you mentioned are kind of inherent limitations of these. A lot of these questionnaires were probably fairly rapidly, devised and sent out. I mean, some of the studies or some of the systematic reviews talked about the quite heavy weighting of the number of questionnaires that were sort of developed and deployed in China. So the sort of distribution across countries wasn't always equal.
Mm-hmm.
And yeah, I think I haven't looked at that specifically, but I think there is an issue with equality in terms of there will be kind of often cross-sectional retrospective surveys.
There have been a number of commentaries about the poor quality of many of the studies on this topic, sort of rapidly, as you said, rapidly rolled out samples of college students, samples of volunteers signed up on Facebook. So I was wondering if you had explored that in particular. And
I think they're good points. I haven't explored that specifically. I think what's interesting is just is the consistency among the figures, even as you start to look at the different groups. So when we look at the figures for health professionals and kind of children, they're kind of similar. But I do agree that we should be cautious of the data, although the trends suggest.
I think your conclusions are right. It's what makes me a little bit nervous, based on perhaps not high quality samples or not high quality measurement, is the prevalence rates, reporting the prevalence rates. I think it's quite clear that the pandemic has impacted people's mental health quite dramatically. But to say, 25, 35% depends on really making population estimates that probably depend on the quality of the sample.
That's a very good point. So that reflects a good limitation to the data I presented.
Okay, Julianne had one small point she wanted to make about, I think, Roxy's question.
Yeah, so I can't speak to that the data more broadly on mental health, but at least in terms of the loneliness data, the meta-analysis that I mentioned in my presentation. First of all, I'll just note that it's not by me, it's by Ernst and colleagues, and it's my understanding is that it's under revision right now, but that data does include longitudinal studies. So these are studies where they had collected data on loneliness at some point prior to the pandemic, and then were able to follow up and collect loneliness data at some point during the pandemic. And these were studies that used validated measurements, tools. And so we do have longitudinal evidence, at least on loneliness. And I can't speak to the representativeness of each of those samples, but I can point you to the registration for that, and that may have data on that.
Great, thank you so much, Julianne. And we only have about 45 seconds left, but Amy wanted to make one quick point or question.
I just had a quick question for Kavita. So first of all, I think the comment about, systematic measurement of psychological distress surveillance, I think that's super cool. But my question was, in the work with individuals who have a psychiatric diagnosis, is there a way to control for individuals who may live in institutional or congregate care settings? So like in those sort of data sets, are you controlling for people who may have had more intensity in terms of exposures to COVID because they perhaps live in the shelter system or things like that, individuals who have psychiatric diagnoses?
It's a great question, Amy. I'd have to go back to the paper to check. My recollection is that this sample was recruited, that it's a community sample, so these aren't people in any form of psychiatric care. So, but it's certainly something I can check. I know their analyses controlled for lots of the obvious confounds you'd think about, like deprivation, age, other illnesses, but that is definitely a good point that I can check on.
Wonderful. Thank you so much, Kavita, for checking into that. And with that, we'll move on to part 3 of our session, focused on psychobiological influences on inflammation and long COVID, as well as the ever important topic of vaccinations. And so we'll kick it off first with Dr. Julie Bauer, who is a professor of psychology from UCLA.
Hi, thanks so much. I'm delighted to be here to participate in this important event. So my colleagues have elegantly described how psychological factors can influence physical health, including effects on the immune system, which we know are highly relevant for defense against COVID-19. Now, we also know that the immune system can talk back to the brain and have profound effects on mood and behavior. And these effects we think may be particularly relevant for long COVID, which is the focus of my brief presentation. So of course, long COVID refers to the lingering symptoms that many individuals experience after COVID infection. And neuropsychiatric symptoms are extremely common. And it looks like actually fatigue is probably the most common of the long COVID symptoms, as well as symptoms including cognitive and mood disturbance. And there is tremendous interest in determining the cause of these and other long COVID symptoms, with inflammation being proposed as a key candidate. So we know that inflammation in the body that is triggered by infection or tissue injury, among other elicitors, leads to the production of pro-inflammatory cytokines that travel up to signal the brain and elicit a constellation of behavioral changes that are described as sickness behavior. So these include fatigue, cognitive problems, and depressed mood, very similar to what we see in long COVID. And indeed, although there's just very few published studies at this point, there is some initial evidence suggesting that inflammation may contribute to these neuropsychiatric long COVID symptoms. And this is going to be a very important area for future research. However, what I really want to focus on today is the important context for these neuroimmune interactions. All of these dynamics are going on within the context of an individual and can be influenced by an individual's psychological state. So there are rich biopsychosocial models that have been developed to explain the onset and persistence of neuropsychiatric symptoms in the context of other disorders. And I want to suggest that these models can be very productively used to inform our understanding of long COVID. So one such model system is cancer. Many cancer patients experience fatigue and other neuropsychiatric symptoms after diagnosis and treatment. When I hear qualitative descriptions of long COVID patients, it very much reminds me of what we see in our cancer survivors. So we and others have shown that inflammation may contribute to these symptoms, and that's shown on the left side of this figure, where cancer diagnosis and treatment is the precipitating factor that influences the immune system, leads to release of pro-inflammatory cytokines that appear to contribute to fatigue. But also important is the right side of the figure. So here we have a host of predisposing and perpetuating factors that influence whether someone experiences fatigue at all, as well as the severity and persistence of this symptom. So we have found that psychological factors are very potent contributors to cancer-related fatigue. So these include stress, including early life stress, also history of depression, a catastrophizing coping style, among others. These predictors are actually much stronger and more reliable predictors than, for example, stage of disease or type of treatment that an individual received. And these factors can impact fatigue and other neuropsychiatric symptoms through effects on the immune system, through effects on behavior, cognitive perceptions of the symptom, as well as sensitivity to inflammatory signaling. So for example, we have found that breast cancer patients who are more stressed after diagnosis and treatment are more sensitive to inflammatory signaling. They're more likely to report higher levels of depression when inflammation is high. And this actually echoes what we see in experimental models where we give people an inflammatory stimulus such as endotoxin, and we see that people who have pre-existing psychological disturbances are more sensitive to the same inflammatory insult. Importantly, and speaking to Judy's presentation, we've also seen that this sensitivity can be buffered by resilience factors. So of course, understanding this context is really important for our approach to long COVID. So it can help us identify vulnerable patients as well as identify targets for treatment. So for example, if inflammation is high in a particular patient, targeting that with anti-inflammatories may be important. If one's coping style is driving symptom persistence or contributing to symptom persistence, cognitive behavioral therapy may be appropriate. So for example, in the context of cancer-related fatigue, cognitive behavioral therapies have been proven to be effective. And finally, our group is very interested in mind-body approaches which work at multiple levels of the mind-body network. And we have shown can both reduce inflammation and associated neuropsychiatric symptoms, including fatigue, depression, and sleep disturbance.
Thank you so much, Julie. And what a great talk. Okay, so we're moving on next to Dr. Neetu Abad, who is coming to us from the Centers for Disease Control and Prevention, where she works as a behavioral scientist.
Hi, everybody, and it's really great to be here with you. I co-led the vaccine confidence demand team in our domestic response, and I'm also the lead for our response, the demand aspects of our response globally. So I'm happy to talk to you today about CDC's vaccine confidence strategy. Let's see, okay, oops. Okay, so this is our, apologies, it's a little bit of a delay in my end. This is our vaccine demand continuum. And this slide shows how willingness to accept a vaccine kind of falls along a continuum. What we often find is though some might fall on the far right or far left, there's actually a large number of people in the middle who may have questions or concerns about COVID-19 vaccines, and they can be reached with better strategies and information. In order to do that, we kind of think about what kind of framework we can use to understand vaccine demand and uptake. And this is a framework that illustrates how complex it is. It's an expert working group chaired by the WHO, which CDC and others participate in, developed a behavioral model specific to COVID-19 vaccine uptake. The factors that are associated with COVID-19 vaccine uptake are kind of what people think and feel. So this is perceived risk perception or disease risk, and as well as how you feel about the vaccines themselves. Social processes are what other people around you are doing or endorsing, and that's particularly important in this pandemic. Motivation or intention to get vaccinated or to recommend them, as well as all of these practical issues which were really highlighted in this pandemic here domestically and globally, which is, do you know where the vaccines are? Are they accessible to you? Do you feel comfortable going to a clinic? All these kind of range of factors. And the takeaway is that there are many factors at many levels that can influence a vaccination, and that these factors can be intervened on. This is the Vaccinate with Confidence strategy that we've been using domestically as well as globally. This is posted online, so as not to get into the details here, we'll say that they're based on 3 pillars: to build trust, to empower healthcare personnel, and to engage communities and individuals in all of our activities. Let's see, is this advancing? Okay, so now that we're engaged, in an intense effort to increase COVID-19 vaccine access as well as uptake globally, we're seeing a range of kind of concerns related to access and service delivery, so inconsistent supply, but also people having difficulty accessing vaccines in trusted locations with trusted providers. challenges related to confidence in the vaccines, as well as how people feel about the health system and their government. So this can be concerns about vaccine safety or efficacy, differing brand preferences of vaccines. So we've got different ones that are endorsed by the US government, others endorsed by other systems, as well as perceptions of the rollout itself. We are also reaching a point of pandemic fatigue and complacency, and this is definitely influencing perceptions of vaccines at this point. We also have infodemic related challenges. These are rapidly changing information environments with unpredictable vaccine related events. And this is also defined by kind of all the multitudes of information that people are receiving as well as discussing in digital spaces. So there is a need to understand and respond to concerns, rumors, information voids, and mis and disinformation. So here at CDC, we have a way of that we've kind of developed in terms of our social listening methodologies. And this kind of is a real-time assessment of public sentiment around COVID-19 vaccination. We analyze public perception and opinions. We identify information gaps and voids, as well as any message issues, and detect mis and disinformation as it emerged. We use kind of qualitative coding schemes such as mixed deductive and inductive approaches. And the themes include ways to act for federal agencies, state jurisdictions, partners, and more. And I'll have an email address at the end where if you want to receive these reports, you can receive them. Let's see. So here we're talking about kind of understanding some of the barriers. This is how we understand our intervention, the intervention side of things as well. So we know that we have to make vaccines accessible or easy to get or convenient, make them seen as beneficial so that the health benefits are outweighing the risk of getting COVID-19 or taking the perceived risk of taking vaccination, make them convenient, reducing any kind of out-of-pocket or social opportunity costs, desirable, normative, and necessary. So this is where kind of the discussion around requirements or incentives or these other strategies come into play. And this is a field guide that we posted on our website that has 12 strategies that partners at all levels can use to increase COVID-19 uptake and demand for COVID-19 vaccines in their community. So 5 minutes goes very quickly. So I wanted to, and apologize for speaking very quickly at the beginning. I wanted to leave on just a few takeaways. We know the demand for vaccination immunization that's going to get more complex, especially as global supply increases. We believe everyone needs to be investing in tailored approaches to increasing demand as well as uptake. And this is the most promising way to reach global coverage goals. We need to build resilience and confidence at all levels in the health system to support COVID-19 vaccine rollout and uptake. And most importantly, and hopefully for this audience agrees, public health must continue to invest in behavioral science at all levels as we prepare and respond to infectious disease outbreaks, which are increasing in frequency. Thank you.
Thank you so much. And so now that we've learned about things that are determining if you get a vaccine, and we're going to hear from Dr. Eric Prather from the University of California, San Francisco, who's an associate professor of psychiatry there, about some of the factors that are determining how your body responds to that vaccination.
Thank you, Sarah, and thank you for the other organizers for this really compelling set of presentations. So right, so obviously, first step, get the vaccine. Second step, what happens and how effective is it, and how does psychological science play a role? I mean, the speed and scale and effectiveness of the COVID vaccine is nothing short of incredible. And to that point, a study by the Commonwealth Fund at the end of this year showed that at least the US vaccination campaign likely prevented 35.9 million infections, 10.3 million hospitalizations, and a striking 1.1 million deaths. However, it turns out that the immunity provided by these vaccines to COVID does not last as long as we need it to. And this is necessitating the role of booster immunizations that are taking place around the world. And so here's data from Israel, published late last year, showing kind of the waning of humoral immunity, or specifically the antigen-specific antibodies, produced as due to the COVID vaccine. And you can see that it wanes over this 6-month period. I think the thing that's most striking about this graph here is that there's clear variability, that some people remain high, but others don't. And we are trying to understand what are the factors that will allow us to predict who will maintain this this protective response and who don't, and what is psychological science have to say about that. Now, there's been 30 plus years of data where people have tried to understand the psychological and behavioral predictors of vaccination response. There are numerous studies. I point you towards this review that was in Perspectives of Psychological Science by Madison and colleagues in 2021 that provides a nice kind of comprehensive review of what we know thus far. But I want to kind of point to a couple specific ones. And so one of the processes that's certainly been related to vaccine response, as you've heard already from prior presentations, and the role of stress in the immune system, that chronic stress seems to be something that is associated with a reduction in the production of antigen-specific antibodies to a variety of vaccines. And so a seminal work by Jan Kiekel-Glaser and Ron Glaser show that chronically stressed caregivers compared to controls mount a poor response to the influenza vaccine. On the heels of the other presentations that we've heard, another thing that is obviously increased over the pandemic has been loneliness. And our leader here, Sarah Pressman, has done some really nice work showing that higher loneliness in individuals mounted poor responses to, again, the influenza vaccine. But it wasn't just how lonely people were, it was also the network, the number of people that were in their network. So not just kind of the subjective experience of feeling lonely, but kind of actually the social contacts in their network also seem to be related to antibody responses. And then kind of moving beyond that, just affect. So positive mood around the time of vaccine has been associated with responses, but also kind of people's dispositional experiences, whether it be high trait positive affect or high as protective, and high negative affect is actually being associated with a reduction in antibody responses, in that case, to the hepatitis B vaccination series. But how does this happen? Well, there are obviously direct effects of these psychological processes on the immune system, but also health behaviors play a crucial role. And there's a variety of health behaviors that seem to be related to vaccination efficacy. So these include things like tobacco use, alcohol consumption, sedentary behavior. All of these things have been related to variability in vaccine responses, nutrition, and then insufficient sleep. So in our work, we focused primarily on sleep as a predictor. As we know, it's related to the immune system. And in this case, in a study where we looked at the hepatitis B vaccination series, we found that fewer hours of sleep were associated with lower responses. And in fact, for every additional hour that someone got sleep, there was a 56% increase. And so what can we do? Can we enhance vaccine responses using psychosocial interventions? This is honestly an unknown. I want to point people to this incredible review by Dr. Vedhara that really takes a look at the literature. On the whole, it seems that there are some modest effects of improving mood and physical activity, but the data is far from clear. There's a lot of opportunities to advance the science, though, and so I want to make a note there that most of the studies to date have been small and the measurement has been spotty. We need to harmonize measures and test them at scale. We need to focus on durability responses versus peak responses to the vaccines. I think moving beyond antibodies and considering cellular immunity is critical, as we've been hearing more and more about T-cell immunity. And then I think we have an opportunity to plan the science now because the need for boosters will likely continue. And so as a field, we have an opportunity to do large scale studies of understanding what factors predict response. Thank you.
Thank you so much, Eric. Okay, and now we'll turn it over to our discussants. We've now heard from all of the speakers, but if you have any questions specifically for our last couple, our last three speakers, let's hear any points of clarification that you have.
I mean, that was super clear for me, so I don't have any questions, but thanks for the interest.
Okay, great.
It's really fascinating.
Okay. Amy
So
or Roxy, did you?
I have no questions.
Oh, go. Okay. All right. So I think with that, then what we're going to be doing is moving on into our coffee break period. Oops, I just skipped past it. We know we've been talking at you for over an hour now, and so we want to give you a chance to have a bathroom break, to get some caffeine as we move into our exciting discussion period. So please come back. I think it's going to be a really exciting time. We look forward to looking at your questions and sharing some of those with our speakers and discussants so that we can have a really engaging last hour of the session. And so we'll see you all in about 15 minutes, and we'll keep this timer up. Also, if you want to, we really want to keep the discussion going for a long time after this talk today. And so if you want to share any, I saw some people sharing resources. If you want to share resources with us, new studies, large scale questions, please feel free to use this QR code by scanning it with your phone, and it will take you to a separate survey where you can share kind of bigger picture questions that you might not want to put in the Q&A, or other things that you want to share for ideas. We'd love to hear from you, and we'll put this QR code up as well at the end. So see. Okay, welcome back, everyone. Thank you so much for sticking with us over the break. Now we're going to begin what I think is going to be just the icing on an already amazing webinar cake. These talks have been absolutely incredible. What these scientists have done with 5 minutes is just, jaw-dropping, really. So we're going to move into letting our discussants take over and really take us to the second goal of figuring out, okay, what's next? What do we do with this excellent science to make a difference for public health? And so, as you know, we'll be led by Dr. Amy Greer, Dr. Roxy Silver, and David Robson throughout this discussion. And I'm going to invite them now to just open up, to start us off by just sharing with us their thoughts. What do you all think about these amazing talks, and what are the big things that are jumping to mind right now? Anyone want to volunteer to go first? I can call on you if you'd like.
I'll go first.
All right, thank you, Roxy.
Yes, so I just want to congratulate the speakers. I know that I've seen this in the chats and in the comments, but the talks have been absolutely phenomenal, cutting edge, very, very clear, so thoughtful, and the package has really been amazing. And as I was listening to this package of phenomenal talks conveying the importance of social and behavioral science on understanding how we're going to navigate through the remainder of the pandemic and beyond, I kept thinking about how we could best disseminate the information today to those who could best use it, and those who need to hear it in particular, particularly those individuals who are suspicious of science, who are suspicious of scientists, who may be, as far as anti-science, and particularly when we were talking about the health disparities and those individuals who might be most susceptible to getting COVID. There are also individuals, for good reason, who might be suspicious of some of the messaging. And I just want to see if any of the panelists have thoughts. I have thoughts myself about how we can disseminate this information, but I'm really quite curious for the people who are presenting such important information that the public needs to hear, how we can best disseminate the information today, because the speakers were able to distill this down in just a few kernels of important messaging. And so I'd like to sort of throw it out there to the speakers about their ideas.
All right, it looks like Kavita is willing to give us an idea on that thought, Roxy.
Well, I'm actually going to ask sort of clarification. Roxy, are you asking about dissemination to the public or dissemination to those people who decide policy?
No, to the public. The people who needed to hear this message about the important role of our minds and our emotions and how that plays out in helping us stop the pandemic or helping us.
So I will come clean with your good self and the audience. One of the reasons we were super keen to have David Robson join us today is precisely for the reason that you've articulated. So David has an excellent track record of taking complex science to the public through his writing in articles and books. And in a way, actually, I'm hoping that one of the outputs from this is going to be a collaboration with David, in which we can take this science and find a way to make it digestible to the public. Because I think for us to really achieve some change in policy, we probably need to exert pressure, not only in terms of the academic community communicating effectively with policymakers, but we also need the public to help generate that appetite amongst policymakers, so that the public are saying, well, actually, I hear all this stuff about what's going to impact on the effectiveness of COVID vaccines. I want to know what the evidence is so that I can prepare. So I think for me at least, I think it's a pincer movement where we've got to achieve both of those things. And I'm hoping, and I don't know if I'm allowed to do this, but I'm going to kind of bounce your question back to David and say, I don't know if what he's heard today has kind of given him some inspiration about how we might do exactly that.
Well, in particular to those who are suspicious of science or are suspicious of academics or are suspicious of the message. And so, David, I'm curious to hear your comments as well.
Yeah, I mean, it's a huge question. And I think it's kind of clear that we've been doing a good job, I think, of communicating science over the pandemic. I mean, if you actually look at people's understanding of immunology today compared to in 2019, I think it's kind of amazing. I'm talking about just the general public actually have already quite fluent in some of the terminology that we would use, understanding the different types of immune responses and kind of questioning what's most effective when we have a vaccine. So I think we have made some kind of progress there. But like you say, I think it's this kind of wave of misinformation that's a problem. It's the kind of vulnerable communities, how do we reach them? And I don't have a brilliant answer to that, but I would just say the quality of the talks today, which I think were communicated, they were absolutely kind of technically accurate, obviously, but they were communicated in a way that I think, a large number of the general public could really understand and appreciate. And I think they really like hearing directly from scientists who are kind of speaking honestly about their research, and also who are kind of sometimes acknowledging the uncertainty of their research. I think there's a tendency or a temptation to kind of be maybe to worry that if you express doubt, then that's going to kind of feed the kind of misinformation pandemic. But my impression, and I think there is some research into this actually, is that that's not necessarily the case, and that actually, say, when you're kind of discussing the uncertainties about kind of modeling of kind of the future waves of the pandemic, that can almost preempt some of the issues that then the people purveying misinformation are going to jump on. Because if you if you let people know that there's this uncertainty, then if things don't go exactly kind of how it was predicted, then people are kind of aware that that was always a possibility, and they don't feel like they've been lied to or misled. So I would just say all of that is, I think, really that kind of honesty of the communication from scientists to the public really does do a lot to build up a lot of trust.
Keely, did you want to add something to the question of getting this information out?
Yeah, I just wanted to follow up briefly. I think Kavita sort of addressed this in her question or clarification back to Roxy, but I do think, in addition to thinking about how to reach the public, thinking about how to reach policymakers is really critical. The people who can actually implement policies that could mitigate some of these negative impacts, both during a pandemic and otherwise. And certainly, as was acknowledged, reaching the public and getting the public to put pressure on their policymakers is one way. But I also think, that puts a lot of responsibility on individuals to take action. And we should also be considering how we can reach policymakers directly.
I also think it's really important for psychologists to be in spaces where public dissemination is already happening. So just like we hear from the epidemiologists and we hear from the physicians, we also really need to hear from psychologists in the public domain on a regular basis. I think also particularly when you're talking about racial and ethnic minorities, trusted sources of communication really vary. So it's important for us to think about actually going into community spaces as well and disseminating information where people are comfortable hearing it in spaces that people trust.
Wonderful. Thank you all for these great insights on, I think what will be a continuing theme throughout this discussion of how do we get this information out. I guess I'll turn back to our discussants, to Amy or David, if you had any big picture thoughts that you wanted to kind of kick off this discussion with.
Yeah, I mean, I'm happy to jump in. I don't often have the opportunity to engage with people outside of my own discipline, and certainly have not had a lot of interaction with psychologists during this pandemic. So this has been absolutely amazing to me. The information has been outstanding, and I've been frantically taking notes, and I'm glad that all of this information is going to be available for me to look at later on. Because, one of the things that really stands out to me is that, one of the biggest things we've seen related to the epidemiological data has been how disproportionately this pandemic has impacted different communities, different parts of our regions. Like, this is not a pandemic that has equally affected people across the board. And, that is an observation. Here in Ontario, we see large outbreaks in congregate care settings, in shelter, in people who are underhoused. We see, significant risk in people who work essential jobs and don't have access to paid sick days, and people who live in multi-generational. The burden of this illness is disproportionately falling on a much smaller sector of our population. And so I think that, to me, one of the biggest things is that, we've epidemiologically tended to attribute that risk to certain factors. And I think that, one of the things that really jumps out at me in all of the presentations has been this underlying, stress related to finances, stress related to all of these different things that really exacerbate that. And that's not something that traditionally as epidemiologists has been on our radar in a way that I think it really should have been when I see the data that's been presented today. And I mean, many people have kind of spoken to that in their presentation. So if anybody, I would be interested in hearing what people think about that.
Go ahead, Anna.
You're muted, Anna.
Okay. Sorry, pressed the wrong button, got confused. I think we're really bad at this. I think we have to own it. I think we don't do a good job at broadcasting and disseminating the results of our science and translating them into language that is usable by policymakers. And I'm not sure that I know an answer, and that's not very helpful just to point out a problem. I get that. But I think, just hearing that, Amy didn't know about this. And I know that, people have turned to public health epidemiologists, to mathematical modelers, and not to us. But should we own some of that? Is that because we haven't done a good job at telling people what we know and why it's relevant and why it's important? It seems to me, I'm not sure that I know how to do that, but I think somehow as a field we have to jump into that in a more responsible way. And I think that this is great, because I think this is what we need to be doing. But more of this and more of getting David to write about this and disseminating it and being part and being at the table is so vital. But I think it's about us learning how to do that as well. That's my thought.
Amy, did you want to respond to Anna?
I mean, I think a lot of it is just like there are not opportunities for this sort of interdisciplinary sharing of information. And the time to do that is not in the middle of a public health crisis, right? Like I think that is one of the biggest lessons, which is that it is, so much of who's at the table is based on previous relationships and trust and collaboration networks of people who have established relationships. For better or worse, that seems to be the way people get to the table. And so, I think that inter-pandemic period is the time during which, and as epidemiologists and as mathematical modelers, we were not all, mathematical modelers during SARS, the original SARS, in Toronto here, modelers went to, the science table as it is, and said, hey, we have tools and methods and skills that we could contribute here. And the provincial government said, ooh, we're not interested in that math, that crazy math. We're not interested in that. That wasn't that long ago. In that inter-pandemic period, we, the mathematical modeling community engaged in an active bridge building with public health to say, here's what we can bring to the table now. And let's work together to build that relationship so that the next time we are in this position, we are a known entity, so that we are invited in instead of, sent someplace else and say, go get your data from somewhere else because we're not interested in that crazy math.
Go ahead, Neetu.
Just the questions that you're discussing right now are, I think, foundational, and I'm loving this discussion, love this opportunity to participate in this. I mean, I've been at CDC for 10 years, and then before that, I was an academic social psychologist. So I think for me, personally speaking, it goes a little bit back to training. I was always very interdisciplinary, kind of stuck out like a sore thumb in my graduate program. When I got to CDC, realized that a lot of people, kind of stick in their disciplines and hadn't considered the value of joining applied workforce. I feel like and I know this to be true, I've gone through now the Ebola kind of response and now COVID-19. There is more appetite for the information that you've shared today than there ever has been before. And it's just growing as governments understand that responses are going to be more frequent, that we're going to have to mobilize differently, that the response structures, if they don't meet the needs of the community, are going to fail. These are all things that behavioral science, psychological science can contribute to. So I would say when it comes to reaching policymakers, you're not going to find a lot of people with very kind of that complex behavioral science background. You have to distill it, make it simple, make it easy to understand, make them understand the impact. This is the way that you can kind of, generate more enthusiasm and people coming to a disciplines that they have not traditionally considered, especially at CDC, where we have epidemiologists and medical doctors everywhere, but not a lot of behavioral scientists. So over, thanks.
So I just want to reiterate what Anna said. I completely agree with you, Anna. And there is an entire science of science communication. The National Academy of Sciences has had several meetings for the last 10 years or so, several incredible sessions, taking risk communication and taking it to a science, and then figuring out how we can communicate. And I think that we, as researchers, need to avail ourselves of the information on the science of science communication. I also want to say we're not trained in graduate school. We don't train our students into communicating to policymakers, and we should not be sitting back waiting for them to reach out to us. And there are people who work directly with policymakers. Our societies, the large societies like APS, APA, other societies have government relations individuals who have very good, strong connections with people, with policymakers. And those of us in universities have government relations offices, and they can help us communicate our science to the policymakers. So it is, I think, on our shoulders. We can't sit back and wait and then bemoan the fact that nobody comes to us, because it's our failing to not be communicating in a way that enables people to see the connections. And as we all have seen this morning, or it's morning for me because I'm in California, but as we've all seen, this is incredible information that really needs to get out to the public, to policymakers, and beyond, to funding agencies. But I want to make one final point, which is very clear in the science of science communications. There is not one audience. There are many audiences. And as we've heard, there are different people, as we've seen throughout the pandemic, and I saw that this was a comment that somebody put in the Q&A, different people have heard the messaging very differently, or distrusting it, or hearing conflicting information. And all of this is very important, and social and behavioral science has the opportunity to help inform this going forward.
Okay, well, this has been a really important, starts the discussion on, communication and, getting this out to the right people. But I'd really love also for us to address some of the questions people have on the content of the talks today. I was wondering if any of the discussants wanted to bring up, either their own burning questions about the talks this morning, and or some of the questions like Roxy was just hinting at that are coming from the Q&A from the audience. Go ahead, David.
Yeah, I had a couple of questions, but my first one was for Judy Moskowitz. I was super interested in, it's amazing the results of this positive emotion skills intervention, but I wondered if you could just give a few more details about what that intervention involved. Like, how did you help people to kind of to be more resilient during the pandemic?
Yeah, so thank you for the question. How much time do we have? I can do it in 2 minutes. So we put together it's a multi-component program that really targets increasing positive emotion based on, a whole history of research, much of it by people on the panel here, showing that even when you're experiencing high levels of stress, like a global pandemic, or general day-to-day stress, or health-related stress, even when you're experiencing that high level of stress, you can also experience positive emotion. And those moments of positive emotion help you cope better. It builds your resources. It may buffer the physical stress response. So there are lots of ways that actually being able to maintain your positive emotion or increase your positive emotion in the context of stress can be really helpful for your psychological and your physical well-being. So we put together a program, noticing positive events, savoring them, gratitude, mindful awareness, positive reappraisal. So we've got 9 or 10 skills that we teach people in this online self-guided version. They go through and they learn a skill or two a week, then they practice it, and then hopefully then they find 1 or 2 that work for them, and then they do it forever, like physical activity. And we've shown across a number of randomized trials that people who learn these skills actually are better off in terms of certainly psychological well-being. So it does increase your positive emotion. It can decrease your depression. We haven't done a lot of studies with physical health outcomes, but in 2 studies in people living with HIV, we showed that people who engaged in these skills actually were more likely to have a suppressed viral load at follow-up, or more than a year of follow-up. So we're starting to put together the evidence that teaching these skills, one thing that we do know is that you have to do them. So our challenge now is to present the skills in a way that people will take them up as habits, which is sort of our biggest challenge.
And I wondered, do you have any resources that people could go to, kind of any free kind of online resources that people could go to if they do want to kind of try out that intervention for themselves?
Mm-hmm. Yep. Yeah, I can share that link.
Be wonderful. Thank you.
Later on, sure.
Amy or Roxy, did you have any favorite questions from the Q&A or your own questions? Go ahead, Amy.
Well, I had a question for Eric, because I think the I caught him off guard. I have a question for Eric about the vaccination, because we've seen all these studies, right, where you show and you get significant heterogeneity. You see the waning kind of as an average effect, but you do see significant heterogeneity. And so in the graphs that you showed related to sleep, how do you know whether or not, like if you say that you have lower antibody response in somebody who sleeps less compared to somebody who sleeps more, but is it below a protective threshold? Like how much less is biologically relevant, I guess, for me is kind of the question. What do we know about that?
Yeah, I mean, that's a great point. And I think it's particularly relevant when it comes to the COVID vaccines, because we don't know yet. There is no kind of agreed upon level to which amount of antibodies are thought to be protective, though I think that information will come, though of course it's much more complex from that. Like some people that have lower levels of antigen specific antibodies might have a really strong T cell immunity and still be protected, right? And very few people ever measure that piece of it, because it's so much more costly. In the specific example that I showed, it was for the hepatitis B vaccination series. And in fact, there is like a CDC cutoff for that. And so in a graph that I didn't show, it turned out that if people got, say, less than 6 hours of sleep on average, they were about 11.5 times more likely to be put in the unprotected group compared to people who slept more than 7 hours. Now, I think that the important piece related to that, like that's a very striking giant finding, but very few people were left unprotected, right? Like it's like the vaccine works really, really well. And, the take home message is not, oh, well, if I'm a short sleeper, I shouldn't get vaccinated. Everybody should get vaccinated. And I think that was, when that finding first came out, that was actually relative to the discussion we were having earlier, like that was a really important thing that I hadn't even considered, that people would have a take home message like that. Right. And so in shaping the message, it was really important. So for that particular one, we do have a cutoff. And so you can use that. And as kind of the science emerges around some of these other things, ideally we'll be able to kind of, because I think those types of findings are really helpful to kind of get people engaged in the science. There's obviously nuance and there's lots of kind of pieces to all of this work that is unsaid to the public, but I think that is really helpful in communication. Yeah.
So I just would like to talk to Julie a little bit more about long COVID. As Eric knows, I don't really want to talk about sleep very much, because one of the sort of people who's when I hear Eric's data, it makes me nervous. But I think that many people are nervous about long COVID. And I think that one of the reasons why people are arguing that people just shouldn't go and try to infect themselves right now and get it over with, which I have heard people articulate, that is because of the possibility of long COVID. And I was, I think there's a lot that we talked about today that is very relevant, I think, in projecting who's going to be susceptible to long COVID and how can we address that. Do you have any further thoughts about how we can encourage more research on this topic, or how we can move forward in trying to help people understand the potential devastating consequences of illness continuing way past the 7 or 10 days?
Yeah, thanks, Roxy. So, it's interesting. I feel like we're still at the point of just trying to document prevalence and get good prevalence statistics, back to your initial question, because a lot of these estimates are coming out of studies of patients who've been hospitalized, or kind of surveys that are fielded through Facebook and social media sites. So I think that's where you're seeing these estimates of 60, 70% of people are experiencing lingering symptoms. There's some really good stats coming out of the UK that are more population-based, that are suggesting something like 1 in 10 people are going to be experiencing enduring symptoms, which again, given the scope of the pandemic, is going to be a huge number of people. I attended a workshop on the biology of fatigue back in September, which was really focusing on long COVID, again, given that fatigue seems to be a really prominent symptom. And what was striking to me was the absence of psychologists. And there's really a focus on the biology. And I think that really intersects with some of the work on chronic fatigue syndrome, where there's been a really strong focus on the biology. And that was, kind of the point of what I was trying to say is like even the biology itself is influenced by psychology. The extent to which our immune system is modulated by these infections is influenced by psychology and behavior, including sleep. And the degree to which we're sensitive to these signals from the immune system is influenced by psychology and behavior. And also then what we do with these symptoms, right, is influenced. This we know very well as psychologists, but I think that this idea that these psychological processes are influencing the biology itself and the degree to which the biology is actually influencing our brain is really important. So I think we're at the very beginning. I mean, really the studies, I organized a symposium on long COVID for the Psychoneuroimmunology Research Society last year. And there are not very many studies at this point. We're really in the prevalent stage. And there's some, really good work coming out of an Italian group that's starting to look at the immune predictors of some of these long COVID symptoms. And I'm sure we're going to be seeing more of that. But I'm really hoping that we can use some of these biopsychosocial models. We've developed them in cancer-related fatigue. They have beautiful models in chronic fatigue syndrome, where they've really been trying to elucidate the psychological and behavioral factors that contribute to persistent symptoms. Those may be particularly relevant because they're really focusing on post-infective symptoms. So I'm hoping that we can be using these frameworks to help understand who's going to be at risk for the persistent symptoms. Because just like with cancer, these are the people who are going to be having morbidity for years after diagnosis and treatment, right? Cognitive problems, depression, fatigue, sleep problems, they can't return to work. This is going to be really have a major impact on public health.
So Julie, just a follow up from one of the audience questions, someone mentioned why there isn't necessarily a relationship between people's severity of COVID and long COVID. Do you think that psychology is responsible for that? So, someone has a mild COVID response, but then it just keeps going. Is that, do you think, to some extent psychologically based?
I mean, it's exactly the same as what we see in cancer. So, I can have a patient who's received the most severe type of chemotherapy and they have no symptoms, really. Maybe, they'll experience symptoms during, but not afterward. I'll have someone who had a little minor surgery and they're experiencing debilitating fatigue. And so clearly it's not just the infection itself or the instigating by, kind of the precipitating factor using that model. It's what's going on with that person is clearly being shaped by host factors, right? And I wouldn't say though, I wouldn't want our conclusion from that to be, oh, it's all in your head then, right? It's all in your head. It's not driven by the biology, because again, like, two people can have the same inflammatory response and one person can have, extensive behavioral consequences of that. And another person, it doesn't affect them at all. And they may, due to alterations in blood-brain barrier, permeability, all sorts of biological reasons for that. But yes, it's exactly why, Sarah, I think it's really important that we need to be looking at these things in the context of the person and their social environment. I'm focusing on psychological factors, but social factors, cultural factors are also going to be important.
Thanks so much, Julie. David, go ahead.
I'm afraid this is another question for Julie, but just quickly, I can't remember if you mentioned this in your presentation, but are you aware of kind of interventions that have actually been tested to kind of target these pathways, either with like cancer fatigue or with long COVID?
So with long COVID, I think we're at the space of individual physicians. I mean, there are long COVID clinics, right, where they're trying to figure out what to do with these patients. And I think here again, we can really learn from, these beautiful studies that have been done over the last decades about how we've been treating these symptoms in the context of other disorders. So I can tell you in the context of cancer, and if we focus specifically on fatigue, but it applies to other neuropsychiatric symptoms, as I mentioned, cognitive behavioral therapy can be appropriate. That's really for people who have had persistent symptoms and their ways of responding to those symptoms have, they thought maybe exercising a lot was going to be really helpful. Turns out perhaps not so much. But our group and others have really been interested in mind-body approaches. And I find those compelling because I think if you're thinking about this neuroimmune network that's influencing the emergence and persistence of the symptoms, I think these mind-body therapies have a good chance at influencing multiple aspects of that network. So we know that those therapies can improve the vaccine response. Tai Chi, Mike Irwin has some beautiful data showing that Tai Chi can boost up the vaccine response to the shingles vaccination in older adults who are very at risk. We know that these therapies can reduce inflammatory signaling, and they can also improve depression, fatigue, sleep problems, et cetera.
Thank you.
Thanks, Julie. Go ahead, Amy.
So I was going to kind of change the direction of the conversation a little bit here because, as a mathematical modeler, early in the pandemic, we published a model that said we are going to kind of limp our way along to a vaccine by implementing and re-implementing public health interventions that act to reduce the number of social contacts that people have. And I mean, that was the recommendation we made. I'll own it. We said, contact rate, this is a pathogen that is transmitted by direct contact. But the implications of that intervention are substantial, especially given the evidence that's been put forth by a number of the speakers on this panel around, loneliness, isolation, all of those sorts of things. So my question to people on the panel who've presented data in that area would be, how do we counterbalance? Because, as an epidemiologist, my goal is to reduce people's exposure to people who are infected. But the downside of that is that it clearly has, important negative psychosocial impact. How do we balance those two things in a way that makes sense?
Go ahead, Kavita. Oh, and then after that, Julianne.
Maybe that Julianne's actually got a proper answer to that question. I was primarily going to say that I completely appreciate and agree with your kind of observation there. I think this pandemic has highlighted a number of ways in which actually the steps that have been taken to reduce risk have had unintended consequences along the way. And what's happened, and it's understandable that this has happened, it came out of nowhere. No country was prepared, possibly apart from some of the South Asian countries who obviously had more recently experienced a pandemic. But we didn't stop to think, well, what happens if you get large swathes of your population to isolate for long periods? What implications does that have for their health? And I think the same is true actually when we talk about, and I think this is certainly, we've got evidence of this in the UK, for very good reasons, all of the public health messaging is about getting vaccinated, and that's great. But unless you present the whole picture to the public, the other unintended consequence of that is that people forget about all the other precautionary steps that you need to continue taking, particularly when there's surges of infection. So we have this belief that once I'm vaccinated, I'm protected. And of course, those vaccines were never developed to give us sterilizing immunity. They just reduce your risk of severe disease. A very subtle but important point that I think was lost in the kind of pandemic debate. And equally, people, once they're vaccinated, behaved kind of as if they were just protected and they couldn't pass on the disease, which again, we know is not true. So for me, I think it is about being very clear about needing layering. For public health policies to work, we need to accept that they need to work in layers, and that there isn't just vaccinations as a solution. And that part of what I was going to say is that I think in the same way that we've developed really, really good surveillance systems now for tracking what's going on with the virus, if we had similar surveillance systems to understand the other part of the equation, which is the public, the host, if you like, then a lot of these things that start to unravel or are the unintended consequences, we'd see them in real time, so that when you see that your public health policy, which is everybody work from home, is starting to spike depression or increases in abuse within families and things like that, then you can act, and your public health policy needs to adapt in real time. So I'm not sure it's an answer, but simply to say that I think it's complicated and we need to address it as a complicated problem.
Go ahead, Julianne.
Yeah, I couldn't agree more that certainly it's complicated. And I know early on in the pandemic, I had very serious concerns about, my own research on, the protective effects of being socially connected and the risks associated with isolation and loneliness, that people would take those findings as evidence to disregard some of the recommendations as well. And in essence, we were faced with this almost impossible situation. It was like being told that the water is not safe to drink. We're still thirsty. We still and how do we fulfill that biological need? And with very little in terms of well-tested tools. And so a lot of scaling of virtual and remote means to connect people without a lot of testing of effectiveness. And I couldn't agree more in terms of recognizing that there needs to also be tracking of these other secondary implications and the unintended consequences, because as we are seeing that this is not just, well beyond that 2-week lockdown, right? Though that many people thought, and we're now into this 2 years. The chronicity of this it has very important implications. And we need to understand this very broadly at a public health level. And so we need to be measuring all of these outcomes and not just certain ones, and adapting accordingly, and communicating the best knowledge and the best evidence available.
Thanks so much, Julianne. So unfortunately, I could listen to you all day, but we're running very, very short on time. And so I'm actually going to invite our discussants now to share with us, some of their sort of concluding thoughts of what's next. What is the important next step we have to all make? What is the missing piece that needs to be focused on right now? What should we really be investing our time in? So let's go ahead and Roxy, do you want to go first?
It's a question that I think, to be honest, my head is sort of exploding with what we've been hearing today. I think the most profound message that I take away is something that we've been talking about the last few minutes, which is that the practices that we engage in for COVID-19 mitigation are exactly those that prolong it or maybe exacerbate it for some people. And I guess, as we're now 2 years into this, it's clear that without attending to vaccine hesitancy and booster hesitancy, we're really going to be in this for the long haul, because the new variants that may or may not come out may require us to pay attention to boosters in a way that perhaps, there's been a lot of talk about vaccine hesitancy, but booster hesitancy and or the feeling that, well, I've already gotten sick, therefore I don't really need a booster. I think all of these things are big challenges for us. And I think that the most important message that I'm taking away from this session is how important these sessions are and how important it is to bring different people with different disciplinary backgrounds to the table. So I wish we had more discussants from virology and from communications, and we only had 3 and we've only taken a few hours to do this, but I really applaud APS for having launched this. And I really hope that this becomes a more frequent event, just like, as I said, the National Academy of Sciences had several meetings over several years on science of science communication. I encourage APS to think about making this kind of information broadly available. But the things that I'm thinking about right now are vaccine, in addition to vaccine uptake, booster uptake, and how we can move the needle on that. Even moving the needle a little bit in the United States will undoubtedly change things. And certainly in other parts of the world, they've been much more effective than we have in getting people to take the vaccine.
Thanks so much, Roxy. And great points. Absolutely, I agree. David, do you want to go next?
Sure. So yeah, I've got a few points. I think firstly, firstly, I'd just like to say thanks to the APS for organising this. It's been super fascinating to me. I think I'm really interested in how this can feed into our discussions of like mental health and mental illness and the kind of resources that are devoted to them. So I think like we have seen a bit of an improvement in people's awareness of the importance of talking about mental health. But I think this research really adds like a whole like another layer to that discussion, because I don't think it's so well accepted at all by the public or policymakers that the effects on our physical health can be so profound. And I actually do feel quite optimistic that when people making those kinds of decisions about funding do realize these kind of broader applications, that they will kind of think more carefully about how they can ensure that the overall level of mental health within a community is generally high and not just wait till someone gets to a kind of crisis point. We also spoke a little bit about science communication, and I just kind of wanted to say that I'm on Twitter at D_A_Robson, and my DMs are always open. And if anyone wants to get in touch with me just for kind of a bit of advice about how they might kind of approach the media, I'd be happy to give that help. So yeah, just saying, I'm kind of there if people would like to talk to me.
Thank you so much, David. All right, and our final discussant, I'm excited to hear what Amy has to say as she's been, at the table, pandemic planning. So hearing what you think about all of this and what the best next steps we can do to make a bigger difference with this research.
Yeah, I mean, I think one of the things that for me continues to come out is something that Keely said in the very first talk, which is, we need to strengthen the social safety net. That the disproportionate burden of this pandemic would be less of an issue if we had a better social safety net just all around, and that one of those things also is related to workplace safety. Much of the issues we have seen have been associated with essential workers who have who are required to go to work, whose risk of exposure is very high. I would guess that your stress about, contracting COVID in your workplace is going to be significantly less if you felt that your employer was actually doing something to try to prevent you from getting COVID, and that was more important than, producing widgets. So I think the social safety net is a huge issue that is important to address. I think the other piece of advice, if you will, that I might give would be reach out to an epidemiologist at your local institution. I know that I will leave here and tell everybody I know, go find somebody in the Department of Psychology at your institution or maybe at a different institution and reach out to them as an epidemiologist, because there's really neat stuff happening there. And so I would encourage you to do the same thing, find somebody who works on pandemic preparedness, find somebody who works in epidemiology at your local institution and reach out to them and schedule a time just to talk about the sort of work that you're doing and how that relates to the sort of work that they do, because building those relationships, I think, is really the first and most important step.
Wonderful. What a great note to end on. We are talking about the importance of social connections, and we're ending with the importance of forming these social connections. So this is just perfect. So thank you all for this fascinating discussion. Again, I think I could have just done this all day and watched you all talk. It's been wonderful and so exciting. But we're going to turn it over to for our final wrap up to Kavita for some closing remarks.
Thanks so much, Sarah. I'm acutely aware we're out of time, so I literally just want to spend 60 seconds or so acknowledging some people that have made today possible. In particular, we have Kieran Ailing and Emily and Cameron, who you can't now, well, you can see their pictures. They have supported us valiantly these last several months as we put this meeting together. They're names to watch out for. They're very talented young academics who I think will be bright stars in the future, and I'd like to thank them for everything that they've done to make this meeting possible. Of course, we couldn't have done this without the APS and their support and their brilliant plan to do this in the first place. So that's Andy and Emily in particular from APS for their support. The speakers and the discussants, we gave you an impossible task. We asked you to deliver some really high quality information in 5 minutes and for our discussants to try and make sense of it all. And you've all just done that amazingly. One of the reasons we did that was precisely because of a theme that's come up time and again in this discussion, which is how do we communicate what's important rapidly and effectively? And I think what we've shown is we do know how to do it. We've just never thought about how to do it. So this session is the beginning of that. And I think this session is going to be very much the beginning of a journey for behavioral scientists really impacting on public health. And last but not least, thank you to all of you in the audience. We've had almost 1,400 people register for the meeting. There's several hundred of you still here despite the time, and we will be taking on board all of your questions and comments. If I can just slip to the final slide and just remind you, we'll be keeping these links open for a couple of weeks. So if as you carry on with your days, you have further thoughts you'd like to share with us, please do, because this is certainly not the end of the process. It's the beginning of the process for us, and we'd love to be informed by what you think. I think Sarah's mentioned it several times, but everybody who registered will be sent a link for the recording. So don't worry, you haven't missed it. You can always listen to it again. So I think with that, I'm just going to say thank you so much, everyone, and thank you everyone for joining us today, wherever you're from. Thank you.